We are so excited to have everybody with us tonight for this training on PRP for hair restoration. We've got two incredible doctors with us tonight, Dr. Shilpi Ketterpal and Dr. Reena Jogi. They'll be talking in two different segments. We're going to start with Dr. Shilpi Ketterpal, who is a fellowship-trained board-certified dermatologist and is currently an associate professor in dermatology and cosmetic surgery at the Cleveland Clinic Foundation. Do you want to come on real quick, Dr. Ketterpal, and say hello? Dr. Ketterpal has been teaching with us for a few years now. And gosh, I would say since 2016, you've now treated thousands of hair PRP cases, several hundred facial treatments, and has been recognized as one of the leading industry dermatologists for PRP and hair restoration. So we are in very, very good hands with Dr. Ketterpal. Thank you for being here. If you want to allude a little bit more to your background and your interests with PRP, and then let's get started with our presentation. And then once you conclude, we'll go ahead and turn some time over to Dr. Reena Jogi, who will be talking a little bit more about the marketing and strategies there.
Great. Thank you so much for having me. I'm really excited to kind of share some information about PRP treating hair. So I was fortunate enough to train at Cleveland Clinic and, work with several dermatologists who really focus on hair. And then for the last 4 years, I've been doing, a lot with PRP, not only treating patients, running some clinical trials, and also, publishing some chapters and papers on it. So it's a topic that's really near and dear to my heart. And I'm really excited to share this information with you. So with that, let's go ahead and get started. So we're going to start off with some background about androgenetic alopecia, or AGA, and then go over some protocols. So just a little bit of background about hair loss in the U.S. It affects, about 50 million men and 30 million women in the U.S. It can start really as early as puberty, and the risk goes up with age. So some recent statistics show that by age 50, about 50% of men are affected, and by age 70, about 40% of women are affected. So this is something, you may be seeing a lot of already, but it is becoming more and more common as people get older. We know it's multifactorial in terms of, genetic and environmental factors. Even though clinically AGA is not inflammatory, we know under the microscope it does have some acute and chronic inflammation. Androgens are really the key at causing this, things like testosterone, dihydrotestosterone. We know that some nutritional factors can also contribute, and it can cause significant stress in your patients. So just looking a little bit at the hair follicle, a brief review, we have different areas: infundibulum, the isthmus, the suprabulbar, and the bulb. So we'll talk a little bit more about how PRP works, but most of what's going on, we're going to be actually acting on the bulb region where we have, our stem cells of the hair. So looking at the hair growth cycle, each follicle, starts in the subcutaneous fat. The growth phase, which is anagen, can last anywhere from 2 to 6 years, depending on the person and their age. Then it goes into the resting phase for several months, which is anagen, and then eventually it falls out, which is telogen. The cycle starts over again. We know as androgen levels go up, the genetics tend to be, kind of expressed. So androgens like dihydrotestosterone and testosterone do cause a shorter cycle of hair growth. It causes the anagen phase to become shortened. The hairs become much thinner. They tend to be more vellus rather than terminal. And then there's a delay in growth of new hair. So all of that contributes to thinning and eventually what people perceive clinically as baldness. So looking at AGA, it is the most common form of hair loss. It has to do with genetic and hormonal factors. We don't exactly know how it's transmitted, but there is a theory that it's autosomal dominant with complete penetrance. It has to do with upregulated perifollicular 5-alpha reductase, and it is more common in Caucasians. There are several scales used to assess the extent of hair loss. In men, we have the Norwood-Hamilton scale, what's pictured here. You can see they start to get some bitemporal recession initially, this M pattern recession, then thinning on the crown. It gets worse and worse until they're left with just a fringe and they're pretty much bald on top. For women, it's the Savin scale. They get preservation of the frontal hairline and then widening of a part. And then, this is the Savin scale starting, very early on, then going all the way to more advanced stages. And once again, it's important to know that their frontal hairline is preserved and then the part just gets wider. So other comorbidities that hair loss can be associated with, because it's thought to be somewhat inflammatory. In men, you can see things like coronary heart disease, prostate issues, insulin resistance, hypertension. In women, hair loss can sometimes be a manifestation if associated with polycystic ovarian syndrome. Once again, that dysregulation of the androgens, also linked with, things like metabolic syndrome like obesity and diabetes. They can get irregular menses, acne, excess body hair elsewhere in the androgen dependent areas like the jawline, the neck, anterior thighs, and then also weight gain. So other types of hair loss, just a brief overview. So, if when someone comes, it's really important to kind of assess, are you dealing with just your run-of-the-mill androgenetic alopecia, or is there something else going on? So telogen effluvium is something where you see diffuse thinning of the scalp. That's just from some sort of, stress or shock to the system, causing more hairs to go into the telogen phase. Alopecia areata is autoimmune. It's basically when the immune cells attack the melanocytes in the bald region of the scalp. So they get, areas that are completely bald, can be very patchy on the scalp or other areas of the body. And it can affect, men, women, and children at any age. Scarring alopecia is not as common as our non-scarring, but essentially you get destruction of the hair follicles and they are replaced with scar tissue. It can be permanent depending on the extent of scar, and it can be associated with other conditions, like discoid lupus is one of them. Other forms of scarring hair loss include a CCCA, or centrifugal cicatricial alopecia, or lichen planopilaris. There's congenital forms of hair loss where, they wouldn't be present at birth. Infections can cause hair loss, other, like folliculitis and ringworm. And then there can also be hair shaft defects when there's damage to the actual hair fiber from external factors like heat or chemicals, and other environmental or hair care issues. So looking at the histology of androgenetic alopecia, you do get progressive miniaturization of the follicular apparatus. There is apoptotic cell death, and you get a decreased proliferation of your keratinocytes and fibroblasts. Even though clinically there's no inflammation on the scalp, there is an inflammatory infiltrate around the follicles, as you can see pictured here. You get a shorter anagen phase, which is your growth phase, and that's the failure of small follicles to reach the scalp surface. You do get a prolonged telogen phase, which is shedding, and that's when your healthy terminal follicles become miniaturized with a vellus or baby hair-like appearance. And a picture here of histologically what AGA looks like, and then clinically in a male. So it's unclear how the androgenetic receptors affect hair loss, but there is a connection between androgenetic alopecia and other medical conditions. It can sometimes be associated with elevated androgen levels, especially in females. However, there are some other factors that aren't identified, like hormonal, environmental, and genetic causes. So let's briefly discuss treatment of hair loss. So it is a large industry with over $3.5 billion spent annually. There are many treatment options. However, not all of them are scientifically proven or FDA approved. A lot of products are marketed to consumers for hair loss. However, they can be ineffective and have little data supporting their claims. And essentially, the outcomes are either to stop hair loss and induce hair growth. So ideally, we want something that does both. So right now, there are a few FDA-approved treatments for androgenetic alopecia. Finasteride, 1 milligram daily, is FDA-approved in men. 2% minoxidil is FDA-approved in women, and then 5% is FDA-approved for men and women. These people need to use these for a long amount of time to get effectiveness, but sometimes they're not always effective. Minoxidil can have significant scalp irritation associated with it, and then finasteride can have sexual dysfunction. So it's important to discuss these with your patients. So a Cochrane review just showed that the efficacy of finasteride and minoxidil together was anywhere from 40 to 60%, and that 40% of men went bald despite therapy, and the efficacy of new hair growth was unsatisfactory, and it caused significant psychological impact, and people don't always see improvement. So despite doing these treatments, people are still left unsatisfied. This was just a table looking at the different treatment options that are available. So in men, looking at, finasteride and dutasteride, which is another oral medication that targets the 5-alpha reductase, looking at minoxidil and surgery. Obviously, surgery is invasive and it does have some downtime and not everyone is a candidate. It is also very costly. And then in women, you can use minoxidil, but you can also use things that target the androgens like oral contraceptives, spironolactone, things like that, which still have limited efficacy. And then in some women, surgery is an option also. So we know that hair loss causes, quite a bit of psychological stress, and studies have shown that these people have an increased incidence of depression. There are many types of hair loss, but the most common is androgenetic alopecia, which is AGA. It's usually a clinical diagnosis, but sometimes, you can do a biopsy or other tools, which we'll discuss further to make the diagnosis. It's important to know to offer your patients that there are effective treatment options and that they should be cautious of some of the products that are marketed for hair loss because they are not effective and they don't always have scientific evidence to support their claims. So with that, let's move on to PRP or platelet-rich plasma. So let's start with what is it? So platelet-rich plasma has been utilized in many fields of medicine before being brought into the, hair restoration and facial rejuvenation world. Orthopedics is really the FDA approval for the joints. Sports medicine uses it, wound healing, sexual medicine, and we know that it works really well. We have a lot of data now showing that it works well for hair restoration and skin rejuvenation. It really has, specific advantages that can help you maximize the biological potential for each patient. And the good news is that there are many FDA cleared class 2 medical devices, and that it's all autologous, meaning it comes from their patient, it's all their own product, and you essentially get a high concentration of platelets in a small volume of plasma. So by definition, you want at least 2 to 3 times the concentration of whole blood. And this is a picture here of platelet-rich plasma in one of these single spin gel separator tubes. So PRP is being used for many things listed here. We're really going to focus on its use in hair loss or alopecia, but know that because of its regenerative capacity that it's used for several other things like scars, wound healing, striae, etc. So let's talk a little bit more about the platelets. We know that they secrete more than 300 active substances. Their key function is in coagulation, immune cell recruitment and inflammation. Wound healing is really what they're meant for. But because during the wound healing process, they do stimulate new blood vessels and remodel the tissue, they contain 2 types of granules, the alpha and dense granules. The dense granules are these small molecules that help in the clotting pathway. They contain things like ADP, ATP, and other molecules listed here. So looking at the blood, in the blood, where are the platelets in the plasma? So inside our vein, about half the concentration of plasma, and then the other half is red cells, and then platelets make up just a very small portion, about 1%. So that's what we're extracting and using for our point of care in our patients. So looking at the alpha granules, they are very important in hair loss. The dense granules serve a purpose, but the alpha granules are really what have the growth factors. This table just shows there are several like adhesion molecules, chemokines, cytokines. The growth factors are really what stimulate the hair growth, like platelet-derived growth factor and TGF-beta. And then you have other peptides that have shown to work on the level of the bulge. So our platelets in a resting state are pictured here. Once they get activated, for example, through the actual injection portion of PRP, like when it passes through the needle, that's enough to activate it. And then when they're activated, that's when it releases all the growth factors from the granules. And that's where you get, your VEGF, platelet-derived growth factor, and all of those that go on to play a role. So we know PRP at the level of the hair follicle, we get increased cell proliferation and differentiation from the ERK pathway. We get the prevention of apoptosis from the AKT pathway. And remember, apoptosis is what happens in AGA when androgens act on the follicle. It causes that large, healthy terminal follicle to become a very small vellus hair follicle, and that's through apoptosis. We get accumulation of beta-catenin also. This essentially promotes telogen, which is our shedding phase, to anagen, which is a growing phase, and makes the anagen or growth phase longer. We also get new blood vessels, and all of this contributes to more hair growth. And we know it also decreases inflammation around the follicle. So the alpha granules, once again, this is showing the different growth factors they have. We have platelet-derived growth factor that helps to repair some blood vessels, stimulates collagen. We have transforming growth factor that helps these cells differentiate. Vascular endothelial growth factor creates new blood vessels. We have epidermal growth factor, fibroblast growth factor, and insulin-like growth factor, which prolongs the growth phase of the scalp. So these dense granules are not as important as the active alpha granules, but they do contain some bioactive molecules that increase membrane permeability, and they can decrease inflammation. So just to summarize, these platelet growth factors go on to do several things in our tissue, including proliferation, migration, differentiation, and angiogenesis. So looking at these growth factors and how they function specifically in hair growth, we believe that the most important ones are listed here. So platelet-derived growth factor, stimulates the growth of your dermis. VEGF increases your blood vessels. Epidermal growth factor can increase the growth phase, which is anagen. Insulin-like growth factor slows down apoptosis, is also thought to be an anagen extender. And then fibroblast growth factor and transforming growth factor beta also play a role in reversing apoptosis. So we know back in 2016 in derm surgery, the mechanism of action was kind of confirmed for PRP and AGA. And this just summarized that PRP stimulates hair growth by creating new blood vessels and encouraging the follicles to enter and extend the duration of the anagen phase through the Wnt pathway, the ERK, and the AKT pathway. So we know that, this was kind of confirming the mechanism of action, and that was several years ago. Since then, there have been many more studies looking at protocols, looking at the single versus double spin, and we'll kind of hit on some of those more important studies moving forward. So dating back to the history of PRP, it was actually in 2006 when it was used by our colleagues in orthopedics to show that it improved elbow epicondylitis and reduced healing time. They found that it accelerated tissue repair and reduced postoperative pain in surgical wounds. And they attributed all the growth factors, chemokines, and cytokines to improved healing in soft and hard tissue. So it's important when you're looking at PRP and evaluating the studies that know that not all PRP is the same. There's different classification systems, and we'll discuss them both. The first is looking at the categories depending on their leukocyte and fibrin content. So the first is pure PRP. This is really the most commonly used form. You have the largest number of platelets and the lowest amount of leukocytes or white blood cells. The second is leukocyte-rich plasma in PRP. This has, your high platelet concentration, but you also have your white blood cells. And this is actually considered a contaminant because we know white blood cells are inflammatory and they can actually damage our tissue. You then have pure platelet-rich fibrin. This is used more in wound healing. And then we have leukocyte and platelet-rich fibrin. So to summarize, all PRP is not the same. It's an umbrella term that does not allow for distinction between available products. It does not take into account your platelet concentration or the presence of leukocytes. So not all concentrates are equal. There are many separation systems that are available on the market, and there's no standardization in dosing. And the lack of standardized method for preparation makes it difficult to correlate the results between studies. So when you're deciding on a preparation system, where do you start? So important to know that this is going to be autologous, meaning it's the patient's own blood. The separation and preparation technique is what determines your final solution, and there's many different products possible. So you can have erythrocyte-free. So, your red blood cells are also inflammatory. So when we're treating the hair, we want to minimize those. You can have leukocyte-rich or poor. Once again, leukocytes are your white blood cells. Those are also inflammatory. So in androgenetic alopecia, we do want to minimize the amount of inflammatory cells. You can have activated or non-activated, fibrin enriched. That's important when you're treating wounds. And, it's really an evolving field. So there's many different ways to prepare your PRP and find, what's best for the patient population and what conditions you're treating. So why not make homemade or do-it-yourself PRP? A lot of these kits available are expensive. So it's important to know that tiger top tubes or, those IVD blood draw tubes should not be used for PRP. And the reason is they should not be used for autologous applications as a medical device because they are not FDA cleared for reapplication to point of care, meaning, once you put blood in them, that's it. They're meant for diagnostic purposes, not for them to be, prepared and re-injected into the patient. There's no way of knowing your platelet concentration, and you'd likely end up with platelet poor plasma. In addition, they can contain agents that are harmful to patients like pyrogens and Ficol, and you don't want to re-inject that into a patient. So it's important to know that, just because something is sterile doesn't mean that it's pyrogen free. Sterility just, ensures that there's no living bacteria. However, if there's pyrogens, sometimes those are not destroyed by autoclaving. And when you inject them, they can really cause problems in patients. So it's really important to know, make sure that the PRP system and tubes you're using, that they are class 2 FDA approved medical devices. So a lot of these IVD tubes actually have a safety warning on them. It says, do not use tubes for collection of materials to be injected into patients. Precautions should be taken to prevent possible backflow from the tube during drawing. And then number 8 highlights here that blood and blood components are collected and are not intended for infusion or introduction back into the human body. So beware of that also. So moving on to the types of FDA cleared class 2 PRP systems, we have on the left here our small volume single spin systems, and those are designed for our medium platelet concentration, so anywhere from 2 to 4 times the concentration of whole blood. Because there is a gel in them, when you spin down your blood draw, the gel is going to pull out your inflammatory cells, so you get less inflammation, low red blood cells, and leukocyte pore. And these are ideal for the skin and hair because, like we talked about before, androgenetic alopecia is inflammatory, as are many other types of hair loss. So in the hair and skin, we really want to minimize the presence of red and white blood cells. This is in contrast to our large volume double spin complex systems. These are geared more towards our colleagues in orthopedics. They have higher platelet concentration, so they can be 5 or more times that concentration of whole blood. But while you get more platelets, you also get more red and white blood cells, so they're very inflammatory. You also take more blood. You're taking anywhere from 60 to 150 mLs. I know with my patients, many of them are young females. They might have low ferritin. They might be iron deficient. So you really want to minimize the amount of blood you're taking. Also, even though you do get a higher platelet concentration, you also get far more inflammatory cells. So you get more of the good, but you also get more of the bad. And we'll talk about some of those studies to show how they play a role when we're treating hair loss. So looking at your final product, also it looks quite different. So here is a single spin tube. You can see that after the blood is taken, it's spun for 10 minutes. The gel here pulls out your red and white blood cells. And then this cloudy area right above the gel, you have your platelet rich plasma. And then this clear area on top is your platelet poor plasma. So there's several companies listed here that do make single spin systems. Then your double spin systems, you're going to have, a buffy coat, and your buffy coat here is where you have your highest concentration of platelets. But as you can see, it's red. You also have a high concentration of red blood cells, and that's what determines your final product. So looking at our final product here, we have our platelet-rich plasma, which is yellow and cloudy. This is from our single spin system because remember, we have low to no red and white blood cells compared to our double spin system. And these have higher platelets, but look, you have this red final product because it has a high amount of red blood cells. So when you inject this, these inflammatory cells have a low pH. It's incredibly painful. So if you're going to use a double spin system in the scalp, know that you have a lot of inflammatory cells, and also your patients are going to have a lot of pain. So you're going to need to do something for anesthetic, either a ring block, or something to manage the pain because of that low pH from the inflammatory cells. For, I personally use a single spin system, and with some ice and, a chiller, patients have minimal to no discomfort. So why is it important to use a single spin system with a gel separator? It's a quick process. You can spin the tube for 10 minutes. It's really simple and easy to use. So you're getting reproducible results for your patients, and it's easy for your staff to follow. It is an FDA cleared class 2 medical device. You get low inflammation, low red and white blood cells. So less likely to have pain, less bruising, less inflammation. And it's very comfortable after the injection because you don't have all those inflammatory cells. So the steps for a single spin system to get a high concentration of platelets, you're going to draw the blood first, around 20 mLs. Then you're going to spin it for 10 minutes. Then you remove your platelet poor plasma. This is anywhere from 4 to 5 mLs. And then you are left with your platelet rich plasma. And depending on the hydration of the patient, you may have anywhere from 7 to 8 mLs, and that you can use in the scalp. So looking at the gel separator systems, looking at like the performance and economics. This is just showing the different ones on the market. So we have, looking at our Eclipse Region Lab Cell Full, and then Eclipse has 2 tube sizes, 11 and 12 mLs. So this is showing the final concentration or volume of your PRP, the total number of platelets that were found, and then the platelet fold of whole blood. And then it gives you a total platelet concentration, and then your price per tube. And the final number here is looking at the price per platelet. So when you know how much PRP you have, how many platelets are in it, the concentration of whole blood, you can do some math and find your cost. So you can see that some of them are going to be more economical than others. And also the platelet yield is quite different in your single spin tubes. And this has to do with, some of these are collecting more blood, 22 mLs. Obviously, if you have less blood, you're going to have less platelets too. So know that not even in the single spin systems, not all tubes and not all systems are the same. It's important to, to look at the differences between these systems and decide what's best for you and your patients. So it's also important to understand the concentration versus the total number of platelets. So the total number of platelets is really the dose that you're administering, and then the concentration is the platelets per ml. So this diagram just shows, whether you have 1 times the concentration of whole blood, 1.5, 2 or 5, it's just a matter of how much plasma it's suspended in, so how concentrated it is. So with higher concentrations, you can give a higher number of total platelets in fewer small volume PRP injections, so it's just more concentrated. So once again, looking at these single spin gel separator tubes, where are the platelets? So if you look right above the gel in that 4 to 4.5 ml, we have, around 84% of our platelets. And then the 1.5 mLs above it, we have, another almost 10%. And then as you go further up, based on weight, you're going to have less and less platelets. So this, the top, I would say 3 to 4.5 mLs are where you have your platelet poor plasma, and then the bottom, 5 mLs are where you have your platelet rich plasma. So once again, this just says 97% of the platelets are in the bottom 7 cc's of the plasma, and the rest of them are just kind of floating on top. So because we know where the platelets are, you can increase the concentration by removing the amount of platelet poor plasma. So because smaller tubes have less platelets, because you have less blood, it's recommended to use a larger tube to get, enough of a final volume. So this is just showing, depending on how much platelet poor plasma you remove, what your concentration is and what, and what volume. So, in my practice, we use the 22 ml tubes. We remove, anywhere from 6 to 7 cc's of platelet poor plasma, and then we're left with a very concentrated platelet rich plasma. So it's a pretty quick process, about 10 to 15 minutes. You draw their blood, spin it down, draw off the platelet poor plasma, and then you resuspend and collect the platelet rich plasma. And then this is just looking again at our gel separator devices, based on density, you're going to have, your red and white blood cells pulled out, and then you're going to be left with your plasma and platelets above. And then this is what it looks like again in your final product. So let's talk a little bit more about what role white blood cells play. We know that leukocytes can be divided into 2 separate categories. We have our granulocytes and our agranulocytes. Ultimately, all of them are inflammatory, so we do want to avoid them in the hair when we're treating hair. So let's discuss more about the role of white blood cells in hair loss. We know that inflammatory neutrophils are present at higher levels in our AGA patients. We want to increase the regenerative process, which is platelet-derived growth factor, without increasing the inflammatory profile. So our ideal PRP concentrate should have low white blood cells and low TGF-beta, and this was discussed in this JDD study. We know that our double spin systems are the ones that are geared for orthopedics, increase the white blood cells anywhere from 4 to 7 times. However, the gel separators do eliminate most of the white blood cells. This was a study from Colorado State University where they compared a single spin system versus a double spin system. They found that the single spin system had a medium platelet concentration and eliminated the granulocytes. However, the double spin system had higher platelet concentrations, but also higher granulocyte levels. So essentially it had more of the good, but also more of the bad. This study was looking at the different PRP systems on the market and kind of comparing them in terms of their number of platelets, white blood cells, and red blood cells. So, you can see looking here at the white blood cells, looking at the ones we have available. So, these are, the Magellan is one of the double spin systems for orthopedics, has, a high inflammatory count. Looking at some of the single spin systems, like CellFill, MyCells, these are the single spin systems, and you can see there's lower white blood cells, and then same thing with red blood cells. So it's important to know that the single spin systems do eliminate a majority of your inflammatory cells. And this was a third party study looking at the different systems on the market. So this study is looking at the role of TGF beta 1 and 2 and how they play a role in apoptosis of the hair follicle. So we know that the TGF beta 1 and 2 actually play a role in shortening the hair cycle, and it actually promotes apoptosis. So we want a final concentration that's low in TGF beta 1 and 2. And TGF beta 1 and 2 is going to be the lowest in your single spin, the single spin gel separator system. So this is very inflammatory and actually causes apoptosis or cell death in the follicle. So this study from Derm Surgery in 2017 actually looked at the histology of PRP and AGA. They looked pre-treatment and also post 3 monthly sessions. So that inflammatory infiltrate was found to be decreased. The anagen phase was found to be longer by increased fibroblast growth factor 7. That thin epidermis was thicker and an increased number of reedy ridges. There was a decrease in the apoptosis regulator, which is BCL2. The perifollicular fibrosis was improved. There was no new blood vessels around the follicles, and they found more organized collagen, and it was very newly formed. And ultimately, this caused an increase of your terminal to vellus hair ratios, and those are your thick, dense hairs, so more hair overall. So PRP kind of reversed all the things we see histologically in AGA, so lots of positive results. PRP has also been used in hair transplant. This was from 2006. They found that follicular units pre-treated with PRP before implantation did better than the ones that were not treated. So, it can be used not only injected into the scalp, but also with transplants. This group was looking again at PRP and hair transplant. They had a group treated with PRP and then a group treated the follicles not treated with PRP, and they either injected PRP or saline after the follicular unit extraction. The PRP group had over 75% regrowth at 6 months and new hair growth at 8 weeks, and over 75% of the graft survived. The non-PRP group or the saline group had less hair growth and then lower graft density survival. So this JDD study was just focusing on things like oxidative stress and environmental factors and their role in hair loss, and why it's so important to have a reduced inflammatory profile when we're choosing your PRP system. So just keep that in mind, looking at the single versus the double spin. This study here from 2016 was looking at our 3 monthly treatments, which showed a significant difference compared to baseline. So they basically had 25 patients with AGA, and they did a split scalp study. Half the head was treated with PRP, the other half was treated with a placebo. They had 3 treatments of 1 month apart, and essentially they found 6 months after the first session, there was a decrease. It was overall more hairs in the growing phase. In the anagen phase, there was an increased hair density and overall hair diameter. So once again, positive results. This meta-analysis of 13 studies basically just show that there is improvement in efficacy in PRP compared to baseline. So they essentially looked at 13 studies and they used PRP for AGA, and they found that all 13 studies showed positive results. So this from May 2017 was looking at the effects of PRP once again on AGA, and essentially they found that there was an increase in hair diameter density, there was an increase in terminal to vellus hair ratios, there was new blood vessel cell proliferation and just overall regrowth, and there was a decreased inflammatory infiltrate, and this was also done with a single spin PRP system. So this study looking at the difference between activated and non-activated PRP. So some of the systems use like an activator like thrombin or calcium chloride, and they actually found that patients who were given non-activated PRP had a more effective or more efficacy compared to the patients that were given PRP that was activated prior to injection. So remember, once those platelets are activated, that's when they release all their growth factors from the alpha and dense granules. So I choose to use a PRP system that does not have an activator, and that's because we feel that the activation happens when you actually inject the platelets through the needle, so there's actually no need for that. So looking at some other literature, this study was PRP with minoxidil compared to PRP versus finasteride. And it was actually really interesting. So they found that after 6 months, the combination of PRP and minoxidil was superior compared in terms of hair count, hair density, and then the anagen and telogen ratios compared with the PRP and 1 milligram of finasteride. So, as we know, hair loss should be treated, with combination therapy. And this study just supported the PRP minoxidil group did better than the PRP finasteride group. So this study now looked at once again, using PRP for AGA, and essentially they used a single spin method, and then they injected it monthly for 3 sessions and then 3 bi-monthly sessions. And they had overall, most of the patients did very well, and they had a successful outcome. So this a study from Dr. Hassauer and Dr. Jones in 2018, derm surgery is really what validated the protocol to treat men and women with AGA. So they had 2 groups. One was a group treated monthly, and then the other group was treated quarterly. So both groups did well. However, the monthly group had almost a 30% increase in hair density, and then the quarterly group had a 7% increase in hair density. So both groups had improvement. Both of them had increase in hair shaft thickness, but the protocol showed that doing their 3 monthly sessions was better than doing 3 quarterly sessions. They did not use an activator. They used the subdermal injection technique. So that's injecting the sub-Q, and then patients had very little pain. It was 2 out of 10 on a pain scale. And they did use that single spin 22 ml Eclipse PRP kit, which gives you your medium platelet concentration and your low inflammatory profile. So this is now the protocol that I follow, and this has been validated in the literature using the 3 monthly sessions as their initial treatment series. So this was a study that Dr. Bergfeld and I wrote, or it was actually a literature review looking at the treatment of female pattern hair loss with combination therapy. So our protocol is that we use a medium platelet concentration, 3 to 6 times the concentration of whole blood, single spin to minimize the granulocytes. We do use the subdermal depot injection. We do believe that the activation happens internally or endogenously. We do 3 monthly sessions and then a 4th treatment 6 months later, then yearly maintenance. And we have found that there's overall positive results for men and women in terms of regrowth, density, quality of life. This was written 2 years ago, and since then we've treated thousands of patients, and majority of them all have positive results and are very happy with their improvement. So this was a newer study just this year looking in derm surgery for PRP compared to minoxidil. So to summarize, the patients had 3 PRP treatments. They had 1 treatment every 4 weeks, so 1 monthly session for 3. This was a high concentration leukocyte-rich PRP. So this was, one of those inflammatory double spin systems. And then at 12 weeks, both PRP and minoxidil groups had improvement, but the minoxidil group had greater improvement. So we felt that the reason for this was because the double spin systems have more inflammatory cells. So even though you're giving platelets, you're also giving a lot of inflammatory cells, which we believe could make AGA worse. So that's why, I believe that the minoxidil group did better. So once again, very important that you pick the right system based on what you're going to be using it for. So this study from the 2020 JAD did look at a placebo-controlled female androgenetic alopecia study where the patients received 3 monthly sessions. They did get the subdermal injections of a high concentration in low inflammatory cell PRP. They did use the Eclipse 22 ml tubes, and there was a 50% improvement in the PRP group at week 24 compared to only 7% improvement in the saline group. So overall, the patients were very happy, and there was definitely a statistically significant improvement in the using the single spin PRP system. So I know that is a lot of studies that we just covered. Please note that they can all be found in their entirety at Revive's website. You can read them through, print them out, and we do update that site with all the new studies because this is a very new and interesting field with a lot of new things coming out every month. So please refer to those. You can print them out and reference them at your leisure. So moving on to the consultation, when you have a patient for hair loss, there's several things you should consider when you're discussing PRP. It's important to know the duration and amount of hair loss. I typically say if it's been more than 5 or 6 years, that it's going to be hard to get those hairs back with PRP because you get miniaturization. And once those hairs have become miniaturized, it's hard to get them to be those thick terminal follicles. It's important to know what they're using now and what they've used in the past. Family history of hair loss, as we discussed before, AGA tends to run in families. Do they have a history of blood disorders? Sometimes that could be an issue when you're, relying on those platelets and their growth factors. And then medications, are they on NSAIDs, any herbal supplements that can make them more likely to bruise or bleed? And then what their expectations are. This is not meant to replace surgery. And, what are their goals? And is that something you can reasonably achieve with PRP? So this is the consent that we use with all the things we discuss at the consultation. It's important that you go over this with them and know that, explain that it's all their own blood product, that they can get some swelling afterwards. Sometimes they can get bruising. It will take time for them to notice improvement, and obviously that there is no guarantee. So now we've been talking a lot about these different PRP systems and how to prepare them. Let's watch a demo video on our actual preparation and obtaining our PRP. So this is our product after our spin, our 22 ml tube with your thixotropic gel. So at the bottom we have our red and white blood cells, and above we have our platelet-rich plasma, and then above it we have our platelet-poor plasma. So now we will go through the separation to achieve your platelet-rich plasma. First we'll wipe the top of the tube with some alcohol. Next we will use a vent needle to remove excess air. Then we will remove the top layer, which is the platelet poor plasma. This can be anywhere from 4 to 5 cc's. So next you are left with your platelet-rich plasma. We will do a vigorous agitation. This makes sure as you gather all your platelets that could be potentially stuck to the gel. You want it to be foamy, but not too aggressive where your gel is disrupted. And now we will draw off the remaining platelet-rich plasma. And this can be anywhere from 6 to 8 cc's. You can see the difference between our clear platelet-poor plasma and then our cloudy platelet-rich plasma, which has all your platelets and growth factors. So now we're going to transfer our platelet-rich plasma with your Lorlock connector into smaller 3 cc syringes. Now your kits do come with a 27 gauge needle, which you can use for injection, or you can choose to use smaller needles like 30 gauge needles. So now that we have our platelet-rich plasma in our smaller syringes, we're ready to get started. So next we're going to discuss our clinical parameters, or, clinically what appropriate patient types they are for using PRP for hair restoration. So we've, now looked over several studies. What are the right patients to use it on? So majority of patients are going to be your androgenetic alopecia. Make sure you pick people that are kind of lower end of the scales we discussed. Avoid ones that are kind of all the way down, because we discussed that once the hairs become become miniaturized, it's very hard to get them back. So don't pick people that are, at end stage AGA. There have been some studies discussing its use in alopecia areata, very limited use in scarring alopecia, because, once you have scar, it's hard to bring those hairs back. So just make sure you have that discussion with them. Contraindications: avoid any active scalp disorders. If they have any active inflammation, obviously skin cancer, and if there's any psychological issues like trichotillomania. Things to kind of considerations, I would say, if they're pregnant or breastfeeding, it is their own blood product. But remember, sometimes you can get things like telogen effluvium from the hormonal changes. So even though it's safe, just keep that in mind. If they have an active malignancy or undergoing chemotherapy, you want to avoid those patients. If they have a history of keloids, also be cautious. You don't want to induce any kind of trauma that can lead to more keloids. If they're anemic or thrombocytopenic, make sure that, these are probably not your best candidates. And if they have any other underlying medical conditions that could prevent them from doing well, like issues with their thyroid, vitamin D deficiency, iron deficiency, anything with their hormones like PCOS, elevated androgens, keep that in mind when you're discussing this with your patients. A study came out showing that NSAIDs might also affect growth factor release. So if your patients are on aspirin or NSAIDs, it might not be a bad idea to discuss that with them. If they're able to hold it, then, that's probably ideal. But sometimes this study was showing that daily use of low dose aspirin actually reduced VEGF, platelet-derived growth factor, in PRP. So that's just one consideration. So next we will talk about, a little bit more of the history. So when you're discussing this with them, other things to consider are the age of onset of hair loss. Are they getting more breakage, or are they actually losing, like shedding it? What's their family history? The pattern, was it, in women, the preservation of the frontal hairline, widening of the part. For women, it's important to ask about their menstrual, pregnancy, menopause history. Many times with your PCOS patient, you'll get the history of irregular menses, inability to conceive, things like that. Ask about their past medical and surgeries, and, do they have any kind of like blood work abnormalities? I don't check blood work in everyone, but if there's a trigger or something I feel like is worth looking into, we will, run a lab panel out and I'll discuss further what I check. Ask about medications they're on, what kind of stress they're under, any kind of special diets or weight loss, if they're using any hair products or treatments, what type of hairstyling do they do, like coloring, hot combing, heat styling, and if they've had a past biopsy, what did it show? So on the scalp, when you're looking at the scalp, you want to look for certain things, things that are common like seborrheic dermatitis or psoriasis. Look for any inflammation. Is there redness, scaling, any kind of scarring? If they have loss of the hair follicle ostia, this is going to be, kind of classic for your scarring alopecias. The hair and nails, look at their part density to assess, you want to see where they fall on that scale. If they have any kind of like hair piece or weave, you might want to ask them to remove it, or a wig. I think you'd be surprised at how good some of these people's hair pieces look. And you want to kind of look at the part with the different areas to see the distribution. So if you're looking at AGA, it'll be very thin on the androgenetic areas of the scalp. So like the top and the vertex, whereas the occipital scalp, you'll have, an increased density. Look for any short or broken hairs, and look at their nails too. If there's, anything with the nails, sometimes those can tie in. And then for the males, you want to look at, where they fall on this Norwood-Hamilton scale. So as you get into your 4s and 5s, this is getting, a little bit tricky, because usually they've had hair loss for some time, so they may not be your best candidates for PRP. In my experience, the 3 vertex and earlier are the ones that do the best, because it's typically a shorter duration of hair loss. For women, you can use either the Ludwig scale, the Savin scale, and that just determines how much thinning they have on the crown. They're usually, their frontal hairline is in place and has not receded, and they get widening of the central part. So always make these different kind of, use a scale that you like, and just make note of that in their consultation. Other things, you can do a pull test at different regions of the scalp. You grab around 40 hairs and gently pull. This is just going to test for telogen effluvium. If you get more than anywhere from 5 to 7 hairs, it's positive. You can use dermoscopy to look at the scalp to look for any like perifollicular erythema scale if you're considering other like scarring alopecias. I recommend using global photography to follow their progress. If you're in a place that has something like a folliscope or a way to get, high resolution images of the hair follicles, that could certainly be helpful. And then if you're concerned about something like that's not AGA, or, you want to confirm your diagnosis of, say, an inflammatory type of hair loss, a scalp biopsy can be helpful. So when you look at blood work and you're deciding what to order, this is kind of a full panel. And like I said, I don't order this on everyone, just if I suspect something's going on. I definitely look at my CBC with DIF to make sure they're not anemic. I look at things like CMP to assess for their like liver function, their kidney function, ferritin, which is their iron stores. Definitely I look at their hormones like the androgens, DHEAS, and testosterone. I do check their TSH. If they are on supplementation, I will check a free T4, zinc, vitamin D. And then, if you're suspecting something autoimmune, you can certainly look into like an ANA or microsomal antibody. For males, it's a little bit different. You can't manipulate the androgens as much, so I don't check them, but I do check your, CBC, CMP, ferritin, and thyroid. Other things, depending on their history, you may want to check. So as we discussed before, there are different differentials that we can look at with our men versus women. So in women, you're going to see thinning along the part, but their frontal hairline is usually intact. Men will get this M pattern recession. If they have like diffuse alopecia areata, it's going to be very patchy. You can get a positive pull test. With totalis, it's more than half the hairs, and you will also get a positive pull test. And anagen effluvium can be seen with things like chemotherapy, where you actually lose the growing hairs very rapidly. And then other things you want to look at, if there's any kind of scaling there, that might be a sign that they have like an infection, like something fungal. And then if there's any kind of scarring, you'll actually see some atrophy, some pigment alteration, and it'll look very smooth because you lose the openings of the hair follicle. So just a little background about PRP for alopecia areata. I've treated a few people with this successfully. So looking at PRP versus intralesional Kenalog, they looked at a split scalp study in 45 patients, and they actually found that PRP was more effective. They found that there were less side effects in the ILK group. However, the ILK group had a higher relapse rate, 63% at 12 months compared to 12% in the PRP group. And it was found to be due to a combination of growth stimulatory and immune modulatory mechanisms. We know that alopecia areata is autoimmune and it can cause significant psychological distress. So there are other things that you can use, but ultimately PRP is a good option. We also know that the hair microbiome is quite different in these alopecia areata patients. And there's actually now more research looking at the skin and gut microbiome in these AA patients, showing that it's actually different compared to their controls. So keep that in mind. And then we also know that probiotics are playing a larger role when it comes to hair loss. So something like, Bacillus coagulans, this is a probiotic, and it's actually found to be changed between patients with hair loss compared to those who don't. So some of the newer nutraceuticals actually contain a probiotic to stimulate hair growth. So this study was just showing that, basically it can be used as an adjunctive therapy of, relieving some symptoms in something like rheumatoid arthritis. But we know that in hair loss patients too, that there is definitely a relationship between the gut and skin more than we thought. So now, we talked a little bit about our PRP injection protocol. We will discuss this in a little bit more in depth. So now let's discuss the depth of injection when you're performing these PRP injections. So a kind of easy way to remember the anatomy of the scalp are the 5 layers. So S is your skin, then you have your subcutaneous tissue, your aponeurosis, the subaponeurotic layer, and then your pericranium. So we're really injecting on the deepest layer, which is kind of your subcutaneous layer, and your subaponeurotic layer. So to find this space, you just gently touch periosteum, pull back maybe a millimeter or 2, and that's the right space to inject these subdermal PRP depots. So looking at the injection protocol, things that you might consider to do is to have like a chiller. You can have something like nitrous oxide, a topical anesthetic, depending on your patients. You want to make sure that you have labels that, you label the tube that you're spinning. Make sure you draw blood into an appropriate size tube. We usually use at least 20 mLs or more to make sure we get an ideal platelet concentration for hair growth. Then you want to have your centrifuge ready. We actually keep our centrifuge in the room, so the patient's tube of blood always stays in the room with them. It never leaves. That way we can have multiple rooms going at the same time. We do centrifuge for 10 minutes. However, each company is a little bit different depending on what system you're using. And then we draw up our platelet poor plasma, and then kind of you're left with your platelet, your 6 cc's of platelet rich plasma in your blood draw tube. So it's all pretty easy to do. It's all done just in 1 or 2 syringes, and you can have everything ready to go pretty quickly. We then invert our tube a few times to make sure we get all the platelets off of the gel, because sometimes those gels can have platelets sitting right on top of them. We collect PRP into your 10 cc syringes. Some people add lidocaine, or they can transfer to smaller syringes. That's really personal preference. And then you can use either like a 27 or 30 gauge half-inch needle. I like to have my patients lying down. If you do have an anesthetic on, make sure you remove everything pretty thoroughly. You can sanitize with something like alcohol or chlorhexidine, and make sure you're able to move the hair. So make sure if they have like a ponytail or any headband or anything on, that you've taken that off. That way you can examine the scalp and make sure you're able to treat your entire treatment area. So then, in our practice, we just use ice beforehand. We start the chiller. We confirm the patient ID. And, some practices do a signature. And then we do a subdermal depot injection technique. So I use anywhere from 0.3 to 0.5 mLs every 2 to 3 centimeters. And you want to distribute it evenly in the areas of hair thinning. And make sure that, I typically tell all my PRP patients, let's go ahead and schedule your series, at the first appointment. So we'll schedule 3 to 4 monthly sessions, followed by a 4 to 6 month maintenance. And then we do kind of yearly maintenance treatment. So we also have them do, home use therapies, obviously medical therapies, and, there's other nutraceuticals and light devices, which Dr. Jogi will discuss more, but ultimately combination therapy is how to get the best results for your patients. So with that, we're going to view a PRP demo with a female patient. So now we will go over our assessment of the female patient. So remember, in female AGA, that they retain the frontal hairline, they get widening of the part, unlike men. So even though we can put a little bit along the frontal hairline here, just remember women will retain it and they will not get any recession. We want to focus on the androgen-dependent areas of the scalp. So we will start with a small amount along the frontal hairline, move back towards the part and along the biparietal region, and we'll finish with the crown. So let's get started. So we'll start with a small amount to the frontal hairline. These are subdermal injections, little pinch, 1, 2, 3. And once again, anywhere from 0.2 to 0.3 cc's per site. There should be very little to no resistance. I also find, with my experience, women's scalps are much easier to inject because your dermis is going to be a little bit thinner, you have less resistance. I'm just putting a small amount around the frontal hairline just to thicken up that existing hair. So next we'll move back. Again, focusing on your androgen-dependent areas of the scalp. You want to see a nice depot. You should be able to see your subdermal injection site. Turn to your left. And I have the patient turn just to make it easier to see where you're injecting. And we do find that icing before and after the procedure alleviates discomfort, and also using a cryo chiller held a few inches away from your injection site. You want to make sure that's not too cold because sometimes it can freeze your syringe. You should be able to see the formation of a nice bolus in the areas that you're injecting. Also, you can have the patient just lift their head, just lift up for a moment, a little bit more. And this makes it a little bit easier to inject the crown. Women are usually going to be fairly thick in the crown, but I still put a small amount there. Okay, come on back. And then now that we have a little bit left, we'll just put some the bitemporal region. Okay, and one more time, last area. Perfect. So the injection process is fairly quick and simple, and then we'll give some ice afterwards to help with some of the temporary discomfort. And then next, it's a little bit different in men. So we're now going to view a platelet-rich plasma hair injections with a male. So you could notice how the male and female placement of injections are slightly different. So in this subject, you can see some more thinning in the androgen-dependent region of the scalp. It's important to note that we don't want to inject any areas where there's no hair, so we can go along the frontal area where there's still some retention of the terminal hairs. Then we will focus along this region here and then a little bit through the top. In the back of the crown, we can go along the area of existing hair, but typically I don't recommend injecting in this region just because it's more vellus hairs and we're not going to get the same effect. This will be a nice time where we can actually see our boluses and that subdermal injection technique. So let's go ahead and get started. So we will start in the front, and it's important to go 90 degrees to the scalp. It'll make it easier to find your subdermal plane, and it also will allow for less discomfort. So this is around 0.2 cc's, and you can see a nice raised area showing your subdermal location. And around 1 centimeter back, a little pinch, a little bit of pressure. Good. Okay, we'll move on back. Great, and if you ever have some resistance, sometimes you can just swatch your needle for a new one and then keep moving on. Little pinch, 1, 2, 3. We'll go along the front here, pinch. Remember that men, especially young men, are going to have a slightly thicker scalp skin, so you might have a little bit more resistance while injecting. And I do see some terminal hairs here, so I'm just going to follow along areas where I'm seeing some thicker terminal hairs to thicken up that region. You can see your boluses as we go along. Can you turn to your right for me? All the way right? Turn all the way this way. Good. Move along the back. Okay, let's have you turn the other way. All the way this way. So we've completed the injections to the front of the scalp. We now have the patient on his stomach, and we're going to finish injecting the vertex and crown of the scalp. So remember, stay in areas where you still see terminal hairs, a little pinch, and we see that nice subdermal bolus, small pinch. So in this patient, we've covered the entire region of the scalp along the existing hair, and since we do have around 1.5 cc's left, I will do small amounts in this region here. Little pinch, because I do see some hair. So if someone it was completely smooth without any hairs, I would not inject that region. Because I'm seeing some sparse terminal hairs, I will put a small amount there. So these raised areas will stay for about 15 to 20 minutes, and then once you're done with the injections, you can give the patient some ice to help minimize any discomfort. And then we have another demonstration of PRP with a male. So here we have a gentleman, mid-30s, who's a very good candidate for PRP. We're going to focus on thickening up the hairline, so we'll do some injections right along the hairline. It's important that you don't inject any areas that have lost hair, but to go right on the border of where there's still hair. Now, even though he's very thick on the top, we will inject this area to help with any shedding, because we know the PRP increases our root thickness and also increase the diameter of the existing hair. So we'll start in the front, move through the top, and then finish on the crown. So we have a cryo chiller ready, and we're going to start with injecting the part. So if you recall, these are going to be subdermal injections, around 0.2 to 0.3 cc's per site. Count of 3, 1, 2, 3, little pinch. So you want to go to a plane where there's very little to no resistance and create a subdermal bolus. And we'll focus right along the part where there's still hair. And you can see that nice bolus with around 0.2 cc's. Go ahead and look straight. So the spacing varies based on the the patient that you're injecting, but I would say around a centimeter between, and you want to make sure you have enough product to cover the entire hair-bearing area. Go ahead and turn to your right. And most people will feel very comfortable during the injection. They might just feel a small amount of pressure. If there's an area that starts to ooze, either you or your assistant can just hold immediate pressure on the site and then continue on with your injections. So here I'm choosing to use 3 cc syringes with a 30 gauge needle. I found that it just creates less discomfort. So now, even though this patient is very dense on the top of his scalp, we're just going to scatter some injections through here. Same thing, around 0.2 per site. And most patients tolerate this really well. You can use ice pre and post injection, and also use a cryo chiller during the injection. And if you find that there is a lot of resistance, you can either try switching your needle or just going to a slightly deeper depth, because in the subdermal plane you should have very little to no resistance. Can you turn to your left? And then I'll have you turn all the way. So we'll finish in the back near the crown. And if you find it easier, you could have the patient turn on their side or even go on their stomach. I prefer just having them turn, and I work around them all the way this way. And we'll do the last few in the crown. So after your injections, you can give them some ice to help with any discomfort. And most of the time is tolerated very well. So for a lot of my patients, I'm finding that combination therapy is giving them the best results. Some of them are resistant to doing, like your oral medications like spironolactone, birth control, finasteride. So for these patients, I find that using a combination of PRP done in the office, something like low-level light treatment, they can do at home. There are several FDA-approved devices, and then there are several oral nutraceuticals and topicals that are also really good. Some of them even include like a multivitamin and a hair supplement and a probiotic all in one, so you can minimize the number of pills that they're taking. So know that your patients are going to do best with combination therapy, and what you do in the office can be complemented with what they're doing at home. So in summary, the protocol that I follow is 3 to 4 treatments done at 1 month interval, followed by 1 treatment every 4 to 6 months for the first year. I do anywhere from I'd say 12 to 20 subdermal injections. They are around 0.3 to 0.5 cc boluses, and we use the 6 to 7 cc's of high concentration PRP with low inflammation, so low red and white blood cells. I personally use ice in a cryo chiller. However, some people do use nitrous oxide in a topical anesthetic. Based on your personal preference, you can use either a 27 or 30 gauge needle. The total treatment time is, around 5 minutes. Once you have your office staff trained to do the blood draws and prepare the plasma, it's a relatively quick process. The charge does vary based on where you are, but, I would say majority of places do charge $600 to $800 per treatment. Dr. Jogi will talk more to you about, how to bundle these in your practice, and, you can even include nutraceuticals to make sure that they're going to complement the treatments that you're doing in the office. And if patients are very committed, you can even discuss or somehow bundle in like a low-level light treatment device that they can do at home on their own. So just to summarize, we are, as you saw, there's a lot of studies and a lot of data showing evidence for the effectiveness of PRP for hair restoration. There is more scientific data needed. We do need to standardize the PRP protocols, including preparation, composition, and activation. We do need more human studies with quantitative analysis, control groups, longer time frames, larger sample sizes, and standardizing our outcomes. But I know in the last 4 years, every month, I'm seeing more and more literature, and it's supporting its use, showing positive results. So it's a really exciting time to be involved with PRP, and I feel really fortunate to be able to offer it to my patients, and I know they are very happy to be able to get this treatment done and have been very happy with the results also. So I'm just going to share with you a few of my patients that I've treated with PRP. These were some of the first patients I treated in 2017, and we're very fortunate to have a good photographer who can take our pictures. So just make sure you standardize your pictures when you're taking them. We do take photos at every visit. So this was after one session. Obviously, we were using combination therapy for her. This was after 2 treatments, a gentleman with AGA, and you can see he's kind of that Norwood Hamilton 2 with that M pattern bitemporal recession and thinning along the part. This was an older patient after 2 treatments. Interestingly enough, he had some darker regrowth come in. We do feel like some of the growth factors actually activate the melanocyte. So not only did he have more hair growth, but he also had more pigmented hairs growing back, which he was happy about too. And we've seen that in quite a few patients. And then again, this was after 1 treatment, doing our subdermal PRP technique on a female in her 40s. So overall, patients have been very pleased with their results. So with that, now Dr. Jogi is going to speak a little more about how to incorporate PRP in your practice. So thank you for allowing me to share this passion with you, and I hope you found it beneficial, and we'll do some Q&A shortly. Thank you.
Thank you so much, Dr. Ketterpahl. I appreciate you going through all of those studies, and wanted to reiterate that all of those studies can be found at revivetrainings.com. I'd also like to make mention that if you want to work hands-on in a CME environment with Dr. Ketterpahl at her practice at the Cleveland Clinic, she has dates on our website where you can go in and work one-on-one with her with live models and receive that support from her. So thank you so much. We are going to shift over and talk to Dr. Jogi a little bit, and then we'll bring you both back on for really the most important segment, which is like your pearls, the takeaways. We'll answer some questions. And again, just want to thank you for your presentation. Hi, Dr. Jogi. How are you doing?
Hi, thank you so much for having me, Kim, and thank you so much, Dr. Ketterpahl. I do a lot of this, and I learn something every time I hear you speak, so that was wonderful.
Dr. Jogi, I have a very long, extensive bio on your background, and you can even speak to that a little bit if you have any disclosures. But what I think I love most about your bio is that you started as a very successful dermatologist, doing everything on the planet that dermatologists do. And when you took training through Dr. Jeffrey Rappaport, who's again one of our faculty members, and really has set himself apart as doing hair restoration procedures primarily in his practice. You learned so much. You took that back. You applied it into your practice, and now how many years later and how many patients later have you really perfected the science of PRP and hair restoration?
It's been about 4 years, and you're right. I was in that seat just a few years ago, and now it's been thousands of patients probably since then, or at least thousands of treatment sessions, and my patients have been very happy. I feel very fortunate for the journey that I've taken, and I feel obligated, or just at least very grateful, to be able to share that with everybody.
Well, thank you for being here. I'm going to go ahead and turn the time over to you. And then if you'll stick around, we'll bring Dr. Ketterpahl back, and we'll have you guys both answer a few of the questions that we have from some of our viewers.
So again, I do have a pretty busy hair loss practice, but I didn't always start that way. And I just want to share with you guys how I was able to transition from doing primarily medical dermatology to doing a whole lot of hair loss, and how I've been able to include platelet-rich plasma therapy in my practice. It has become a very large part of what I do. I'm very fortunate for that. I'm very fortunate that I have patients who are able to be grateful for the treatment I'm able to provide. And a lot of that is in large part to what I have learned. So I hope to pass that along as well. We're going to cover the art of the hair consult, how you can combine treatment options, the best way to both attain patients as well as retain patients, and then just overall office strategies and materials that can be helpful. So to do a hair consultation, Dr. Ketterpaul already went through a lot of the basics of the history that it's important to take. It's very important to spend a lot of the time with your patient and really make that patient feel like you're listening to them and actually listen to them, because hair loss is a very emotional journey. It is a big struggle for a lot of patients, and that connection that you can make, it really translates further into their trust in you. And if they trust you, they're going to listen to what you recommend, and that is very important. I don't really need to repeat a lot about the history and all of that, but you do really want to make sure you listen, not only to connect with the patient, but also to make sure that you're ruling out any underlying causes, any medical hair loss causes. And in that vein, you'll be able to tailor your treatment options the best way. You really want to set expectations for both the results as well as the entire process. A lot of patients will come in at the 1 month mark and expect to see drastic improvement. And if you set the stage at the beginning and you let them know that they may not see realistic improvement until about the 6 to even 12 month mark, they will be a lot happier because they'll be more patient. They'll be able to sit through this journey. You want to explain that there's going to be a loading phase with the treatment. Within the first year, it's going to take a few treatments stacked. And I follow the protocol that Dr. Ketterpaul follows as well. We do stack treatments monthly for the first 3 or 4 treatments, and then after that, ongoing maintenance. You really want to start out by explaining all the treatment options and then find the approach that fits best for the patient medically, as well as that fits best with the patient's budget. I really try to encourage patients to pursue combination treatment modalities for a couple of reasons. If they do a combined approach, they're going to have a better outcome. A lot of the studies do show that if you combine PRP with other treatment modalities, the patient does better. And if they do better, they're going to get that buy-in very early on. And if they're committed to something, if they have something that they can do every day or twice a week or 3 times per week, it does let them take their focus away from stressing out about the hair loss to doing something very proactively. And I think from an emotional standpoint, that does make a big difference. So again, diagnosing hair loss, Dr. Ketterpaul really went through this in great detail, which I thought was fantastic. And I think it's very important, again, to get a very thorough history. You want to really pay attention to their family history, not only to know where they are, but perhaps to project where they might be. If their father lost all their hair at age 40, well, then you really do have a timeline to project towards, and that can help tailor how aggressive you may or may not want to be. Medical history is very important during laboratory evaluation when and if appropriate. Trichoscopy is helpful, as well as dermoscopy. I think it's important to look very closely for any signs of inflammation, as well as to rule out any evidence of a scarring alopecia, because those patients will not do as well. And for PRP, we do know that the sweet spot is androgenetic alopecia. So if you select your patients wisely, you'll have better results. You'll feel better about doing the treatment, and that will translate into your overall success. You want to really rule out anything that might be causing hair loss, such as excessive coloring or bleaching treatments, keratin treatments. You want to make sure they don't have any additional symptoms such as itching, scaling, burning, or anything like that. Any major shifts in their dietary habits, as well as general medical and family conditions. And once you've diagnosed the androgenetic alopecia, it's important to set in stage a treatment plan. Treatment plans do make people feel very empowered about their hair loss journey. And I think that that's a big part of it. Helping people feel like they're taking control does help the hair loss from an emotional standpoint, at least to take that stress out of the equation. And I do find that a lot of patients tend to fixate a lot on their hair. Some don't. Some are very able to separate, but many do almost feel like they're looking at the mirror on a day-to-day or minute-to-minute basis. So it's important to give them something that they're able to take control of. So combination therapy, this is a great article that was written by Dr. Ketterpaul. She's in academics and I'm in private practice, so we come from very different places, but I'm very fortunate to be able to benefit from a lot of the literature and studies that she so tirelessly puts out. So, and we all can benefit from that. This was a nice paper that outlined how combination therapy can be very beneficial for patients. There are so many treatment options out there, and there are a lot of treatment options that don't have a lot of evidence or science behind them. So it's nice to stick with the ones that actually do have evidence behind them so that you can make sure your patients are not confused and that they do have a good plan that they can take home with them. As physicians, it's very important that we guide patients through these and help them pick the best treatment options out there. There are definitely a lot of options out there, and one of the most common is systemic anti-androgens. So these include things like oral contraceptives, spironolactone in females, or 5-alpha reductase inhibitors such as finasteride in males or in postmenopausal females, and in rare cases, flutamide. Some of these medications do have unwanted side effects. In finasteride in particular, it can cause sexual side effects, and it's important to counsel patients for these because there are a lot of patients who will choose not to pursue that approach and may prefer other non-pharmaceutical options. There are topical therapies that are out there, and these include pharmaceutical grade topicals as well as non-drug topicals. One of the gold standards is minoxidil, which again comes in a 2% solution or a 5% solution or foam. And minoxidil has a long-standing track record. It works in a good number of patients, about 40% will notice benefit. It's really important if you start this at the same time as you start PRP to counsel them about the fact that they might get shedding during the first 2 to 8 weeks of therapy. This is important because some may falsely attribute this shedding to the treatment with platelet-rich plasma therapy, and it is far more likely to occur with topical minoxidil. The side effects of that can be limiting for some patients. It can cause some itchiness, it can cause some flaking. In some female patients who are very sensitive, it can cause hair growth on the face, which is a very unwanted side effect. So counseling about these is very important. One thing that does make people very hesitant to use this treatment approach is they have heard all over that once they start this medication, they have to use it forever. I do try to counsel patients that persistence with this does kind of translate to all treatment modalities. Everything is something that you have to maintain. And so they just have to decide what they're comfortable maintaining. Zinc parathione is another ingredient that can be helpful, and it's found in a variety of shampoos. This one is thought to inhibit 5-alpha reductase, so it's good adjunct to therapy with minimal side effects, although it can also cause irritation and itching. And then there's also topical ketoconazole, which is available in a 1% shampoo over the counter or 2% shampoo as a prescription. And this is thought to reduce dihydrotestosterone in the hair follicle. Again, side effects with any topical are going to be irritation or itchiness. And in some patients, it can actually increase oil production, whereas in others, it can cause dryness. Some patients, again, are very wary of pharmaceutical topical options, and they really don't like the idea of having to do something forever or the idea of the prolonged shedding phase at the beginning of the treatment course really does disconcert them. So there are some non-drug topicals that are out there, and ideally, any product that is going to work is going to have a variety of ingredients in there. So Redensyl is an ingredient that is naturally derived. It contains dihydroquercetin glucoside, and that is thought to stimulate anagen by supporting the outer root sheath of the hair follicle. And in some studies, it has done very well compared to placebo. And in a couple of studies, it has outperformed minoxidil. This is an option to provide patients, and it is found in the topical supplements that's in the topical analog with the Votest supplement. It also has caffeine, which is thought to decrease DHT and increase circulation, which is an important factor in hair loss. There is Serenoa cerulata fruit extract, which is a natural 5-alpha reductase inhibitor, as well as ginseng root extract, which suppresses apoptosis. And then a variety of growth factor products and peptides can also be found. These type of active ingredients really are helpful in terms of relaunching the anagen phase and reducing the telogen phase of the hair follicle. And with consistent use, you can find anywhere from a 9% increase in anagen phase at the 3-month mark, as well as a 17% decrease in telogen at the 3-month mark, which is very important. Anything that can stop shedding will really help patients so that they can notice that improvement a lot sooner. So combining with oral pharmaceutical options or with topical non-drug options or topical pharmaceutical options, there are also nutraceuticals. And nutritional supplementation has become a very large part of the hair loss industry. There are so many supplements that are out there that it is difficult for patients to sort through these. There are a variety of them that are physician dispensed, and these are the ones that most offices are familiar with. They're also the ones that many patients are familiar with because they have a lot of brand recognition. So of these, there are three main ones. There's Votess, Nutrafol, and Viviscal. All of them are physician dispensed. However, Nutrafol and Viviscal can also be found on Amazon and online. And for some patients, that might be very appealing to them. For some practices, it's a little bit more appealing to have something that is only available in the physician's office. That does two things. One is it does actually distinguish your office a little bit, but it also keeps the patient coming back to the office. And if they come back to the office, they will be more consistent and compliant with their platelet-rich plasma therapy treatment sessions. You can combine these again with oral treatment options such as spironolactone or finasteride. So supplements are a huge market, and anything that's going to treat hair really has to have an ideal combination of ingredients. One of the big ones that's out there is soluble keratin, which strengthens the hair follicle. Biotin is common in a lot of hair, skin, and nail supplements. However, there is an FDA warning that I'll touch on in a little bit, but a lot of hair supplements do contain this. There's also turmeric root, which is known to reduce inflammation. There's niacin that helps improve circulation and helps provide oxygen and nutrients to the hair follicle. Saw palmetto berry is found in a lot of hair loss supplements, and that can inhibit 5-alpha reductase, which is the enzyme that converts testosterone to dihydrotestosterone. Ashwagandha root extract is a very nice ingredient because it acts as an adaptogen. It's shown to contain antioxidant properties. It's basically thought to be a natural cortisol inhibitor, so it helps reduce that stress hormone and helps reduce inflammation. So I think of it as something that helps the body adapt to stress as well as help the hair follicle adapt to stressors. There are many other ingredients, including phytosterols, green leaf extract, nettle leaf extract, pumpkin seed concentrate. And ideally, a nice hair loss supplement is going to have as many of these as possible. If you compare the three main ones that are out there, there is Nutrafol that contains vitamin A, vitamin C, and vitamin D, but it also contains soluble keratin, very much like Votess does. It also contains ashwagandha root extract. Viviscal doesn't have these two, but its primary mechanism of action is the shark cartilage. Both Viviscal and Nutrafol have biotin in it, and it's important to keep that in mind. I'll mention in a little bit why it's important to keep that in mind. Votess notably does not have biotin. What I like about Votess is it actually can act as a multivitamin. So it is something that can help reduce the overall number of pills that a patient may have to take. It has polypodium leucotomus, which is an antioxidant that helps provide an intrinsic SPF. And it also has a probiotic, which is known to be helpful in hair loss. Biotin is important because in reality, although it's been around for a long time and patients come in having tried this because it's all over the internet and their friends and girlfriends and boyfriends tell them to give this a try, there's very little scientific evidence that biotin actually improves hair health in patients unless they actually have a pre-existing biotin deficiency. And it's important to remember this because biotin is actually known to interfere with certain potentially life-saving lab tests. The most important of these is the troponin assay, which is checked in patients who are having a non-ST elevation myocardial infarction. So you can have patients who might have a heart attack that's missed because they're on biotin. And that actually has happened with very undesirable outcomes. It can also affect with thyroid assays, which is important when you're treating hair loss patients, because if you're have patients who are on biotin and they have abnormal thyroid function tests, they might be inappropriately treated, and that can actually worsen hair loss. So it's just important to either counsel patients very heavily on this, or in my personal preference, I actually try to stay away from this these days. Other treatment options that you can combine with are microneedling. So microneedling can be done either in the office or it can be done with home rollers. There are a variety of home rollers that are out there. And if patients are going to pursue this, you're going to want to counsel them to get a home rolling device that can be sterilized, because otherwise it is quite unhygienic. But there are some patients who do microneedle with the application of minoxidil, and that can be beneficial. There's also low-level laser therapy, which Dr. Ketterpaul has touched upon. And low-level laser therapy is thought to stimulate more of the anagen phase and promote increased blood flow to the scalp, and doing that via laser treatment. And the ideal laser is going to be something that has a wavelength that is as close as possible to infrared. So something with the 678 nanometer wavelength is going to be ideal. There are a variety of laser devices out there, and all of these are for purchase by the patient and for them to do at home. There is the HairMax, which has the headband, as well as the laser comb, which some patients find the comb to be a little bit cumbersome because it takes a little bit more work and effort. There's also the Capillus, which is a baseball cap, and there's a Theradome helmet, which is pictured here. And all of these devices, they range in price anywhere from $400 to $3,000. For my patients, I typically like to give them all the treatment options and counsel them on what my preference is. Again, the ideal helmet is going to have the right right wavelength, as well as many lasers as possible. And this particular device does have 80 diode lasers, which is nice. It's quite comfortable and it's hands-free. And the hands-free component, I do believe, is very important in terms of maintaining compliance. Patients really don't have side effects with this, and patients do notice benefit with it. It's cordless, as many of these devices are cordless. And I particularly like the price point, although in fairness, I think a lot of the devices that are out there are fine. You just have to find the one that works the best for the patient and guide them towards that. So how do you attain patients? I think it's best to be authentic and to tell your story, where you came from, how the practice started doing PRP. You may want to share videos on your website or on social media. I think it's important to talk about how PRP is very much a now thing and how it really wasn't available to us 10 years ago, and how makes it a very exciting time in hair loss. You want to talk about the safety and the efficacy, the cost as compared to other approved therapies, and the downsides, which are fairly minimal. Some practices do offer free hair consultations. As a practice that takes insurance and treats medical dermatology, I stay away from doing this as it might be viewed as a kickback, depending on what type of practice you have. Educational brochures in the waiting room or in the patient rooms are very helpful. Patients pick these up and they ask you about it while they're waiting for other treatments or other medical conditions. And it's very important to just remember that pictures are worth 1,000 words. If you want to show a video loop, the consultants at Revive Training Consultants have a great video loop that you can use in your waiting room, and that's been very beneficial. You may want to consider adding a form on your website or to your patient intake forms for patients to indicate whether they're interested in non-surgical hair growth options. And then you may want to consider an email list so that you can share e-blasts and you can share success stories. Other modalities include television or cable ads. You may want to pursue a radio ad depending on your market, newspapers and magazines. A lot more people are reading them these days, and a lot more people are in their car and commutes. And so as many avenues as you can pursue, the better. You may want to network with primary care physicians and let them know that this is a treatment option that you offer so that they can recommend it for their patients or for physician colleagues. Hair salons are a great place because they're the ones who see your hair loss patients on a more regular basis, and so they can recommend you. Social media, Facebook, Instagram, Twitter, all of the goodies, have these as optimized as possible. And then of course, you want to do your SEO optimization for Google. YouTube videos, if you can have a couple out there, or if you put these on your website or put these available for patients to view, they can always be helpful. And then of course, patient recommendations. Your referrals from other patients are going to be one of your greatest sources of PRP patients. You do have to be careful if you offer some sort of referral program. Again, that might be viewed as a kickback. It depends on whether you take insurance or not. So just be wary of that. But if not, you might consider a referral program of sorts. This is a small segment that we did for a local television spot, and I live in Houston. A lot of people view this during the day, and it was just a small segment that was great. It got a lot of viewership, and it was nice because we were able to put this on our website and feature this, and patients still view it.
Well, welcome back. If you're experiencing some kind of hair loss, you are definitely not alone. It's very common for men to experience a receding hairline or thinning hair at the crown, and even for women. Common hair loss is typically thinning hair all over the scalp.
Yes, and do not be ashamed, folks. There is a new treatment for common hair loss called platelet-rich plasma therapy that stimulates hair growth. And here to tell us more, please welcome Dr. Neda Nasrati, Dr. Rena Jauki, and Tiffany from Dermatology.
Hello.
Hi, ladies.
Hi.
Thank you so much. You know, I think for women, or maybe men too, no one wants to talk about hair loss.
Yeah, that's true.
You know, hair loss is such an emotional topic. I always say that more tears are shed in our office for hair loss than things like melanoma. It's a very, very distressing thing.
Absolutely.
And unfortunately, a lot of people don't talk about it, and they kind of internalize it and stress about it. But fortunately, there are great treatment options now.
Especially in women, you know, I think for men it's something that's sort of expected and common, but in women it's extremely distressing because they don't expect it.
Right.
And this procedure, I mean, especially when women have like a thinning hairline, it makes the part look a little bit wider.
Exactly.
So this therapy, tell us exactly how it works, because I understand it involves some injections.
Yeah, absolutely. So basically, platelet-rich plasma is where we're harnessing your own body's growth factors to kind of trigger the stem cells in the hair follicle to, you know, grow thicker, healthier, more sort of dense hair. And so we use a blood draw. We take your blood just like if you were going to get lab work done, and then we re-inject the platelets into your scalp. So it's very easy, quick.
And we're seeing on the screen a little bit about how the process works.
Exactly, yeah.
And so this is stimulating actual hair growth with one treatment.
Well, it's a series of treatments.
Okay.
So it's a series of 4 injections. But, you know, it's simple. It's not something you have to do every day like a lot of other hair treatments.
And what if somebody, so this is called androgenetic alopecia. That's different from alopecia, correct?
Alopecia is just a generic term that means hair loss.
Okay.
There are a lot of different types of alopecia. Androgenetic is the type of hair loss that's kind of driven by hormones.
Okay.
It's the typical male or female pattern hair loss where you see those typical patterns with thinning.
We're going to get into this, and we're looking at the before and after pictures here on the screen, and we're going to do it here in studio.
That's right.
But, like, I lose a lot of hair. I shed a lot. Should I be concerned?
I think any time that you're concerned, it's not a bad idea to make an appointment with a board-certified dermatologist so that they can take a look, because there's a lot of things that can cause shedding. There's a condition that's called telogen effluvium that's really common with chronic stress or after a particular stressful situation. But it's very important that someone look at your scalp and make sure that there's not anything else going on.
All right, let's get started.
Yeah, Tiffany's been sitting here very patiently, so you're going to do some of these injections then, yeah?
So we have her lay down, and then you have the syringes ready
We have everything ready to go. So we did this back at the office. So she got her blood drawn, and we sort of spun it down. And so what we're going to do today is actually do the injections here, so you can kind of see how quick and easy it is to do it. And, so,
And her concern is basically in the front. Is that where we're looking?
It's in the front and a little bit all over. Tiffany is, you know, she has gone through a lot. I mean, I think as a lot of people, she has a familial tendency. She has a strong family history of hair loss. Also, just, you know, medical concerns with her daughter. Recently, after Hurricane Harvey flooding, I think she was like, that's enough. Time for me to do something for myself. She saw a lot of our patients get great results and has been excited to do it.
How many injections, by the way, are, sorry to jump in, yeah, go for it. How many injections are required, and how often does someone have to do this?
So it's usually a series of 4 treatments, about a month apart.
Okay.
And after that, most patients, they do a maintenance treatment maybe once or twice a year.
Tiffany, can you tell us what you're feeling? Does this hurt?
No, not at all. It's actually a really small needle, and I mean, I can barely feel it. At our office, we have a Zimmer, which blows cold air that helps with any pain that you're feeling, but it's extremely easy.
Okay.
This is actually
I think and everybody's pain level is a little bit different.
You're right.
Tiffany is one of the tough ones. It's a minor discomfort, and afterwards people feel a feeling of fullness of the scalp, and that lasts maybe about a day, but it goes away very quickly. You're able to resume your normal activities, go about your life. Really no downtime.
What about the results? Because, I mean, like, how long after this injection happens would a patient expect to see results?
So typically, I think you start seeing results at about 6 months. It's one of those things where, like, a watched pot doesn't boil, a watched scalp doesn't grow hair overnight.
Yeah.
Right.
It's the type of thing that you might not notice yourself, but all of a sudden you have other people coming up to you saying how great your hair looks, how healthy, how long, and how much it's growing.
Doing
and
great.
then the before and after is really
say all the difference in the world.
They really do speak for themselves. I mean, we were blown away when we saw the photos. Where does this compare? I mean, I know there's lots of over-the-counter remedies to help with hair growth. I mean, is that sort of a temporary thing? I mean, this is more long-term, right?
It is definitely. And hair loss is such a huge industry. I think there are billions and billions of dollars spent on it. And unfortunately, a lot of treatments are out there that aren't scientifically sound or not really proven. Now, certainly there are some things that work, but the thing that we like to say is that if all of those worked really well, we wouldn't see any bald men around.
Very true.
So, this is one of those things that does provide long-lasting results. You do have to do maintenance treatments, but they're not as frequent. It's not something that you have to apply to your scalp every single day. Side effects are really minimal. It's exciting.
And by the way, we should point out, you doing okay, Tiffany?
I'm great.
Okay, good. You can go ahead and take a nap down there. That looks very comfortable. And this is just one of the many things you do.
One thing to keep in mind is that we had thought about so much about this segment and what to say and getting ready for it and what to wear. What we forgot to do was prepare our staff for this. And after we finished this segment, we immediately received an influx of phone calls, and the staff really almost had no idea to expect this. So one word of advice, do prepare your staff. The response to this was fantastic, and it was more than we had expected. We were already doing a lot of PRP in the practice, but it did help kickstart it a little bit. And it is important to make sure that your staff is prepared. And if you do something, this was a live segment actually, so if you do something like this, make sure that your staff is going to be ready for as soon as that segment airs, depending on what time of day this is going to show. That was a nice little lesson that we learned. And so to retain patients, you have acquired them. The best patients are the ones who are already your patients because they already like you and they're already loyal to you. So you want to take pictures at each visit if possible. Invest in a very good camera. We actually in our practice really use the iPad to take pictures, which is not the best camera, but it does integrate with our electronic health record. And so we take that convenience over the other option. However, if you are able to invest in a good camera, it will make a huge difference. You do want to show the patient evidence of growth in various areas over time. Patients are very, very grateful to see these pictures. And a patient stares at himself or herself every day, so they're not going to notice a significant amount of hair growth because you don't notice that gradual change. So if they can see that with pictures, it does make a difference. And setting and managing expectations is a large part of this. It does take a little bit of hand holding often, and you want to be very truthful about the process. Keep as detailed patient records as possible with as many photos as you can. And if you're able to, if you have the staff capacity, follow up phone calls to see how the patient is doing or to make sure that they haven't fallen off the radar. You may want to consider offering maintenance discounts for patients so that when they pursue maintenance treatments, it's a little bit more affordable for them. And you may want to consider bundling packages because patients do need multiple treatments. And I did find at the beginning when I was not bundling packages, they had a little less buy-in and I had patients less likely to follow through regularly. And since we know that monthly protocol is better than a quarterly protocol, for instance, it is a good idea for them to be on board and for them to be kind of on the hook to get the right treatment protocol for their condition. It's really important to make this a good experience for your patients, and that often means creating specific duties for specific staff members. It streamlines the process. The patient prep process is very important for blood draws, also in terms of having people who are experienced in labeling tubes and making sure that that plasma stays in the room with them. We do what Dr. Ketterpaul does, and we have the centrifuges in the room as well. But for practices that are not as busy and they might have only one centrifuge, you really want to make sure you follow a strict protocol so that you avoid any untoward mix-ups. You may want to have staff in place to help with scalp numbing, or we have staff who helps with the chiller device that we use in our office. And it's very important to have people who are experienced in preparing the PRP in the right way, because if they prepare it properly, then your patient's going to have a good outcome. And if you have staff members who are able to keep and maintain follow-up call lists for patient tracking, that can be very beneficial as well. And this is a nice timeline that kind of outlines a great approach to the patient. So on the first day you meet the patient, you will do the consultation and decide to pursue with PRP if that's what they choose. And at that treatment, day, it's a good opportunity to provide them a 3-month supply of a nutraceutical. And I do carry Votest, but there are a variety out there. Again, Viviscal and Nutrafol are also options. I like the Votest because it's the nutraceutical oral as well as the foam therapy, but there is no wrong answer there. You may want to do prescription therapies at that visit and add low-level laser therapy, either something that you carry in the office or something that you recommend for them. And then a month from then, you're going to do their second PRP treatment. And then a month after that, so at about day 60, you'll do their third. At the 90-day mark is an optional time to do treatment number 4 in our practice. Because we started doing PRP before some of the studies came out, we do typically do that optional 4th treatment, but it varies on a case-by-case basis. At that visit, it's a good time to refill their 3-month supply of the nutraceutical. Every hair loss intervention can take about 4 to 6 months to notice a response, so it's important for them to re-up on that. And then at day 120 and day 150, they continue the nutraceutical, they continue the low-level laser therapy. That way they haven't forgotten about their hair loss, they stay on the hook, they stay committed to the process. And you see them at about the 6-month mark, and you may want to consider doing an optional PRP session at that time. We consider that their first maintenance session, and that's a good time again to refill their nutraceutical. And these vary in retail anywhere from $200 to $300. It's an affordable option for many patients. It may not be affordable for everybody, but for most patients who are able to afford PRP, they're also able to afford the nutraceutical. And then you carry this out really for the whole year. They continue their treatment options. They continue their low-level laser therapy and their nutraceuticals, and you may consider doing booster treatments along the way. So in that first year, they may get up to 6 in-office treatment sessions. They might get 12 bottles of the oral nutraceutical and topical foam. And prices do vary everywhere from $600 to $800 per treatment session. If the patient is paying for 4 treatment sessions up front, that's $3,200. You may want to consider including the first 3-month supply of their supplements so that they do feel they're getting a value added. I believe in value added as opposed to discounting treatments, because I think that patients do feel like they're getting something a little bit more rather than you feeling like you're lessening yourself. And the total cost to the patient can vary depending on what they bundle it with, anywhere from $3,200 to about $6,000. And it is common practice for practices to provide a discount if they're doing it on a quarterly or biannual maintenance for PRP treatment sessions after the first year of therapy. Marketing materials are very important, and we have a lot of this stuff in the office, and thankfully Revive Training Consultants does have a lot of this stuff available on their website. We have the brochures, we have some brochures that we've had from before this, but these really are top quality, and I've been very grateful to have them. The lobby looper, I think, is extremely helpful, that video loop that you can play in your waiting room. And banners have been very successful in our practice because it's just like a large thing that the patients can see when they're coming in for something else. And that's something that's kind of nice. You can convert patients who are there for something else or who might be struggling with hair loss, but maybe didn't realize that they could ask you about it. And you want to share your before and after success stories. You want to be as authentic as possible with them. I'll just go through a few of these. This was actually one of my, not my very first, but one of my first patients, and he had just a couple of sessions of PRP done. He fell off the radar and came back at about the 6-month mark, and he just mentioned how it wasn't working, and I just made him take pictures anyway. And then he saw the top of his scalp and immediately did 2 more sessions that day and the next month after. So again, the importance of pictures cannot be overstated. This is probably one of my youngest patients I've ever injected, and she had a great benefit from this. She had so much hair that I couldn't even part it, actually, and you could see so many baby hairs. And she was an adolescent, actually, and struggling with terrible hair loss that she was feeling very self-conscious about. And this ended up being kind of life-changing for her, and you can really dramatically impact a person's life. This is an older woman in her 50s or 60s, and she is, I mean, older than the other patient. That's not old, but this is a patient in her 50s, and she had a great response after 4 treatment sessions. You know, I actually keep this picture because I don't love it, but it's good to remember that photo quality is not always going to be perfect, but it still might show what you want it to show, because the photo on the left is a little overexposed, but it's not always going to be perfect. It's just important to take as many photos as you can so that you can document their journey. This is a patient who had a hair transplant done years ago. So having a previous hair transplantation is not a contraindication to PRP. In fact, many patients do notice then that while the transplanted hair follicles stay strong, then they start having that progressive miniaturization of their native hair follicles. And so he was very happy with this treatment approach because it did provide for longevity of his hair transplantation. And this is the same patient in the back. This is another woman who's in her 60s, and again, treatment options are variable. She did combined treatment with topical minoxidil, and after 4 treatments, she did notice improvement. I like to keep this picture to remember to think about the temporal areas, because in a lot of women in their 40s, this is the area that bothers them the most, because this is the area that they see on a regular basis. And so the temporal areas can respond quite nicely to PRP. And this is after 3 sessions, and this is PRP therapy alone. Again, another temple and another response. Temples can be kind of subtle, but patients really notice the improvement and they feel very grateful for it. And this patient was in his young 20s, and he grew so much hair that you almost couldn't even believe it. We wish we knew what was particularly in his platelets so that we could market that, but he did great and was very happy. A young college student who, you know, really didn't want to be losing hair at that age. And sharing these stories are very important. This is actually my husband. I always like to tell people I prefer him with hair, and then we just leave it at that. And a patient with both alopecia areata as well as androgenetic alopecia. She improved from a standpoint for both of these conditions. She has not, interestingly, had a recurrence of her alopecia areata since we started doing PRP, and now we've probably been about 3 or 4 years into her journey. And prior to that, she was getting flares all the time. And again, another woman in her 60s who had improvement with PRP alone. This particular patient did not want to do any other treatment modalities, but a lot of patients will do better with combination treatment. And then I like to keep this picture in just as a reminder to stay authentic. You don't want to sell pictures that are not true to what they are. This patient heard about all his treatment options. His plan was to try minoxidil, come back to me for PRP. If he didn't get better, he came back and was so happy that he had gotten better with minoxidil alone. So sometimes a simple option is the right option for your patients. And sometimes a combination approach is going to be what's right. The important thing is to stay true to what is going to be best for that particular patient and try not to oversell or undersell anything. And with that authenticity, you'll have the best results. And so now I think we're going to probably roll into our question and answer session.
Yes, thank you so much, Dr. Jogi, for all of that insight. And we do have quite a few questions. I think this is sometimes the most important part of our lecture, is answering the questions that our students have. So I'd ask Tara Chatham to come on, and if you want to just field these questions to both of our doctors, and then we'll also type them up and we'll send them off to you in handouts. You're going to get most of these PowerPoint slides in your handouts with the purchase of this training. So don't be worried about that. And actually, both of our physicians have hands-on days, one in Houston, one in Cleveland, if you want to go in and actually treat patients for hair restoration. Both of them have that opportunity available. So Tara, with that, I will turn it over to you for some Q&A, and we will wrap up the night.
Great. Thank you, Kim. And thank you, ladies, for sharing your expertise and all of these incredible takeaways for our viewers. We so appreciate both of you. We do have several questions that have come through. Again, we'll just reiterate that many of these will be typed up that we don't address this evening. I'll kind of field them to both of you independently, and then if you have something to add, please just feel free to step in. This one comes to you, Dr. Ketterpaul. Can you get shock loss from PRP at all?
So that's a good question. Can you get telogen effluvium from PRP? I believe there's been one case report with that happening, but it was with one of the double spin systems where they had, higher amounts of inflammatory cells. So in theory, yes, but it's really, really rare. In the thousands of treatments that have been done, not only in my practice, but, all over the country, there's just one case report. So I suppose in theory, but my thoughts are, they used a double spin system and there may have been more going on with the patient's history that, that maybe could have explained it rather than the PRP itself.
Okay, great. Thank you. I'm going to stick with you here for one more. Have you used PRP for any female patients who are on hormonal therapies for breast cancer or for permanent hair loss post-chemotherapy?
That's a great question. So yes, in both situations, I have used PRP. So I've had several patients who are on like tamoxifen and are in remission from their breast cancer, and they are doing very well with PRP. I've worked closely with our oncologists to optimize their like combination therapy and make sure we're cautious with any oral systemic medication that can manipulate the hormones and kind of running it by them. And then I do have a fair amount of patients who have had anagen effluvium while they got chemotherapy. Their chemo is now over and they still had some residual hair loss, and we've been able to get them some pretty good success with a combination of PRP and some other therapies like minoxidil.
Great, thank you. Dr. Jogi, for patients concerned about side effects from finasteride, which combination therapies do you use for them?
So if patients are very wary of finasteride and they don't want to take it, you can do a compounded finasteride, so it can be available in a topical solution if you compound it with minoxidil. So that's one option. You may want to consider in that patient one of the nutraceuticals that contains saw palmetto, which is a natural 5-alpha reductase inhibitor. So it kind of accomplishes a similar goal, but with a much more natural approach that in a lot of patients, they feel more comfortable with that approach because it can minimize side effects. And then we just have to talk about what their specific concerns are. And if they are just slightly wary of finasteride, some of those patients do actually give it a try and find that it is better tolerated than they anticipated. And some patients just absolutely don't want to give that a try. I think low-level laser therapy is a good treatment option for any patient type, whether they're on finasteride or not.
Okay, thank you. I'm going to stick here with you for kind of a combo question. One is, which patients would you turn away or help manage their expectation? And have you seen that hair growth is permanent with PRP treatments?
So that's a good question. I think the type of patient, it's not about turning away a patient, it's about managing expectations. And so if a patient comes in and they are in the later stages of hair loss and, just kind of more advanced, you still, you don't want to turn them away really. They're still your patient. You might want to approach them in a different way, but they probably are not the best candidate for platelet-rich plasma therapy. You don't want them necessarily pouring that money down the toilet. You might want to guide them towards a hair transplantation instead, and then they can do platelet-rich plasma therapy or other modalities in conjunction with that. And then I do find that platelet-rich plasma therapy, just like with any hair loss intervention, is not permanent. You will get natural degradation. And so the hair growth that patients get by about the year mark, it will start to naturally degrade. And so that's why maintenance therapy sessions are so important.
Okay, thank you. Dr. Ketterpaul, is there any patient diseases that are absolute contraindications to PRP that you consider?
Sure. So contraindications, if they obviously have any active malignancy in the scalp or in the area you want to treat, you want to avoid that. Also looking at if they are on like blood thinners, not just aspirin, but things like, Coumadin or some of the other newer blood thinners, you want to be cautious because you've actually kind of altered some of the the growth factors and like kind of the whole clotting cascade. Other things, if there's any active infection or dermatitis in the scalp, you want to be cautious of that. If they have like a systemic cancer, if they're on chemotherapy, I think those are all things to be cautious about. And then ultimately, if they are undergoing treatment for something else, just make sure you're, keeping their other physicians in the loop to make sure that they're okay with moving forward with PRP if you have any questions.
Okay, Great. Can you touch once again on scarring alopecia, the results you've seen, and what you would continue to treat with PRP, if so?
Sure. So, I've had a handful, I'd probably say between 20 and 30 patients with scarring alopecia that I've treated. It's really difficult to know their response because you can't just clinically looking at them determine the extent of scar. So majority of my patients have been CCCA or LPP. And, I have a really honest conversation with them that look like we don't know if this is going to work or how much hair we'll have to, we'll be able to get back. I typically like to wait until their disease is quiet and they're not having like a lot of inflammation or any symptoms like itching, burning, or pain, and that their disease is pretty quiet and stable. And then we'll have a discussion about, giving a trial of PRP. Sometimes they'll even do a trial of like minoxidil or an oral anti-androgen to see if they'll regrow hair and then maybe add PRP. But I've had, success and some failures when it comes to that, but patients are usually willing to try. And if they're looking for more aggressive treatments, then sometimes we'll discuss hair transplantation.
Okay, thank you. Dr. Jilgi, I have a couple questions here for you. How much additional benefit have you seen with the complementary therapies, or who have you considered just poor candidates for PRP, also considering age restrictions?
I really don't feel that there are any age restrictions for PRP. My oldest patient is probably in his 80s and actually responded quite well. And it's one of those things that it's very hard to predict. My father actually has had it done and he's 75, has responded really well to that. It is very hard to quantify what degree of response patients are getting from combination therapies if you start them all at the same time. I think that does make it a little bit difficult. I think that there's an advantage to doing it that way because patients start to respond a little bit more quickly. And at the end of the day, most patients in my experience, they really don't care what gets them the result. They just want to get the result. So it is a little bit more difficult to quantify that. And we're not an academic institution. We don't do clinical trials here. But in my experience, if they've tried one approach, let's say PRP, for instance, and then they're not exactly where they want to be, they do get a marginal or pretty decent improvement if you add additional therapies, but it's hard to quantify.
Okay, and Dr. Ketterpal, would you add anything for that?
I would say my approach to, to treating the hair is a little bit different in the sense, like I start with like the least invasive options first. So many times we'll do like a nutraceutical, like a supplement and like a topical, and then I'll see them 2 to 3 months later. We'll look at the photos and then maybe we'll add an oral medication, then we'll add PRP. So, I think we all kind of have our algorithms in our mind, but I agree that I don't think age is really a cutoff. I think it's really more duration of hair loss. And I think you have to kind of assess each patient. Some of them are weary just to do everything at once because, PRP is great, but it is expensive. And I think you want to be realistic with them. It's not in everyone's budget. So, if they can get some improvement without having to do it, that's great. But I really like to see it as a ladder. And I certainly, see them back every 3 months and we add treatments each time until they're happy with the results.
Okay, thank you both. We just have a few more here. I'm going to stick with you, Dr. Ketterpal, for these next two. It says, do you think needle size affects the viability of platelets?
So that's a good question. And I believe it's been looked at like the diameter of like a 30 gauge needle and the diameter of a platelet. So I think if you're 30 gauge or larger, you're not going to run into any problems. If you're trying to use like 32 gauge insulin size syringes or needles, I think you might run into problems because a platelet is, you might cause some issues with looking at the diameter, but I think if you're a 30 or larger, that you're not going to run into any problems. I personally use a 30 gauge and we haven't had any issues. I also think patients have kind of less pain and less bruising using a 30 gauge compared to a 27, which is what I used when I initially started.
Okay, good point. Do you have any AGA patients who are non-responders to PRP? And if so, how do you address them?
So I have had, I would say in the several years I've been doing this, I've had 2 young men who were non-responders. And, they kind of had the classic history of AGA and a strong family history and dads and brothers and males. So, they were doing topicals and they wanted to add PRP, and then neither of them responded. And then actually once we did a little more investigation and I did some blood work, I found both of them had, androgens or their DHEAS in the 1,000. So there was like a little more going on. So, just your run-of-the-mill hair loss patients like AGA, I have not had any issues with or problems with getting a response, but just those 2 young men who happened to have like an underlying endocrine abnormality, they did not respond.
Okay, thank you. Dr. Jogi, a couple here for you. When should a patient stop the use of their NSAID or their aspirin or non-steroidals? And then also, how important with that taken into account is it to follow your protocol, your timing?
So typically you want a patient to stop their nonsteroidals or their aspirin about 10 days. The life cycle of platelets is about 7 to 10 days. And so if you stop that at the 10-day mark prior to treatment, then it's going to give adequate time for those platelets to replenish. And I'm sorry, I didn't follow the last part of your question.
Just how important it is for your patient to stick to that kind of first initial treatment, the timing of the every 30 days.
Oh, okay. That's like the treatment protocol. Well, I think it's important, just both in my experience as well as in the studies that were outlined. If you follow that protocol of doing that first treatment and then following it up with a treatment a month later, I think that they get a good benefit. And I always like to tell them that it's important to try to follow that as much as they can, because really, when, like that one study by Dr. Hausauer showed, they did get a better outcome if they were treated monthly than if they were treated quarterly. So I think it's important to stick with that.
Okay, thank you. Dr. Ketterpal, can you kind of go over just real quickly, I know we spent some time, but on your single spin versus your double spin, your advantages there or disadvantages, and then also the optimal platelet concentration?
Sure. So, just outlining single versus double spin, the single spin systems do have less inflammatory cells, so red and white blood cells, and you get like a medium platelet concentration anywhere from 3 to 4 times compared to the double spin, where you're going to have a higher platelet concentration, maybe 5 to 6 times the concentration of whole blood, and you're going to have higher inflammatory cells. So, for the hair, we want to minimize inflammation, so using a single spin system. And, I think ideal platelet concentration is at least 3 to 4 times the concentration of whole blood.
Perfect, thank you. As far as activating with calcium chloride, do you think it leads to a longer growth factor release, or is that true?
From the studies that I covered and that I've read, using an activator, it does not seem to show improvement. In fact, the groups that were not treated with an activated PRP did better than the ones that were activated. So, most of us believe that the activation of actually injecting the platelet into the scalp is enough to activate it and release the growth factors then. So, I personally don't use an activator, and that's just following, a lot of the literature and comparing the activated versus the non-activated PRP.
Okay, thank you. Dr. Jogi, what options exist for measuring your hair follicle counts, or that you are using in your office to track progress?
So global photography is a very important tool, taking global pictures of the scalp. If you have a more academic practice, or if you have the means, you can get a follicular scope, which will actually measure the hair count. There are a couple of companies where there are pretty low-tech devices where you can actually take pictures with their scope and it uploads it to a portal, and then they have a company that actually counts the hair follicles. And so there are a variety of options that are out there. They can range in price from pretty cost effective to extremely expensive, and the more expensive devices are probably used in academic centers where they're doing clinical trials and studies, and they're probably a little cost prohibitive for the standard practice.
Okay, thank you for that. Are you injecting lidocaine superficially at all prior to PRP injections?
So I personally don't inject lidocaine superficially prior to the procedure, but when we're drawing up the PRP, we do add a very small amount of lidocaine without epinephrine. And that it's a very small amount, but that does help with some of the discomfort and the burning that patients feel both during the procedure as well as afterward.
Okay, thank you. And Dr. Ketterpal, can you tell me, is it better to inject the PRP at the level of the bone or skull versus more superficial?
So, based on several of the studies, based on like the depth, so I do the deeper subdermal injection compared to an intradermal. And the reason is, there's less pain receptors, and because you get some diffusion based on the level and the depth, compared to like an intradermal injection to cover the area. You're going to need more injections. It's going to be more painful. So most of the literature is showing, both groups, intradermal versus subdermal, will get improvement, but it's less pain and less injections if you do a subdermal technique.
Okay.
So that's basically when you touch the bone or the periosteum and just pull back a millimeter or two, there's very little resistance there.
Perfect. Okay, and then last question, ladies. Major difference between PRP versus PRF?
So I'll just touch on that briefly. The platelet-rich fibrin is going to be higher in your inflammatory cells, so your red and white blood cells. Most of its literature has been shown in like the wound healing realm. So, that fibrin matrix is really used as, to stimulate that wound healing response. So looking at its use for the hair and skin, because we have those high inflammatory cells, you have to be cautious given that even, AGA has some inflammation there. It's kind of more the profile of a double spin system compared to your single spin low inflammatory cell profile.
Okay. Well, ladies, thank you so much both for being here. We really appreciate your expertise and sharing all this information with our viewers. And thank you for those that have attended tonight. We hope the takeaway is great. And again, thank you so much.
Thank
you.
you.